Firstly, I would like to introduce the first speaker of this workshop today, Dr. Doan Lam Tu, MS. He received graduate certification in Doctor of Dentistry from University of Medicine and Pharmacy, Ho Chi Minh City in 2016. He was a dental implant resident in UMP from 2016 to 2019. And he received many awards like the Grand Travel Award and speaker at International Conference Second ISCADR in Indonesia in 2019. And he received runner-up poster award at HSDI in 2019. And he also the author of international publication in the field of bone regeneration in 2020. And right now he's working as a private practice in implantology and periodontal surgery. His today he will share with us as a topic, peri-implant soft tissue augmentation to optimize functional and aesthetic outcome. Please welcome Dr. Doan Lam Tu.
Thank you, moderator, and thank you, all of you. And hello, everybody. I'm Dr. Doan from Vietnam, and today I'm very honored to be here to share my case and share my knowledge about one of the most hot topics in implant dentistry is the soft tissue augmentation around implants. So first of all, I want to give the thanks to ACRO company and the organizer, the moderator invited me today, and thank you all colleagues are listening my presentations. You know that nowadays implant dentistry has become standard protocols for the dental tooth loss. Some author and clinician recommend 3 criteria for the peri-implant soft tissue to maintaining a long-term success of the implants. For one, is obtaining a 2 mm of the mucosa thickness around the implant in each side around the abutment, and the second one is we have to have a 3 to 4 mm of the supracrestal tissue height, measuring from the bone cresta to the mucosa margin. And the final criteria is we have to demand keratinized tissue around the implant, not only for maintaining the health of the peri-implant side for a long term, but also we have to have the natural emergency profile of the prosthetic. The more implants were places, the more chance we meet these scenarios like two picture. In the left picture, we can see that the implant surface were exposed and the food debris stuck it underneath the prosthetic. The mucosa is swelling and bleeding on propping. And in the right picture, you can see that this is raised and the buccal defect in the peri-implant mucosa after make the final prosthetic. And so, what are solutions for these scenarios? Remove the old implants, making a bone grafting and making the soft tissue augmentation. So today I want to focus on the soft tissue grafting to optimize the aesthetic, functional and biological outcomes of the implant therapy on the short and long run. If you have a buccal concave and you want the more technique of the soft tissue, you have to make a soft tissue grafting. If you don't have the keratinized tissue, you have to make it to get more keratinized tissue, especially in the buccal. And in the post-extraction side, we want to have a soft tissue to cover the bone grafting underneath, as well as the implant. We have to make the soft tissue grafting. That's so quite interesting case I want to introduce to you today. The case with the old prosthetic and the tooth break, and we have around 2 mm of the gingival recession in the mid-buccal with the thin phenotype. This is the picture after I make the soft tissue grafting. You can see that the very nice outcomes with I can get them thicker phenotype in the buccal areas. I have a more keratinized tissue, and I can get the soft tissue coverage after extraction the tooth. And so let's talk about the 3 time point of making a soft tissue augmentation around the implants. We have 3 time point. The first is pre-implant placement. The second is simultaneously with the implant placement, and the second is the post placement, as well as the post lasting after the delivery, the final prosthetic. And honestly, in my practice, I very like making a soft tissue wrapping in comparison to the making the hard tissue, and maybe I like to make the soft and hard tissue in the same time. So let I show you some case. With the first case in the lateral incisor area, you can see that this is clearly so thin of the buccal mucosa. So my treatment plan is make more technique with the pouches flap, the pouch technique. In this technique, I use the 15C plate to make a split technique flap in the buccal side, from the apical to the coronal to the buccal, and be careful avoid to perforating the buccal flap, because we can lead to the scar formation, as well as we reduce the healing potential of the surgical side. After that, using the collagen matrix from ACRO company, trim it and make it exactly the same size with the pouches flap that I created before, and stuck it entirely into the pouches flap. And you can see that they are more thicker immediately when I stuck the flap in. And I hope the result will remain until the completely healing of the soft tissue graft. Last but not least, the stabilization of the graft is so important. It's have an important role in the healing of the soft tissue grafting size, with 1 suture in the apical and 2 suture in the coronal. Replacement of the provisional prosthetic, and this is 2 months follow-up picture. From the occlusive view, we can see that it's clearly more thicker than pre-operatively. In the front view and in the lateral view, you can see that I can mimic the natural emergency profile in comparison to the contralateral size. So we move on to the second case, in which we lost the 2 teeth. The first tooth is broken in the central incisor, and the another one has lost it for a long time. They buccal concave in the lateral incisor, and so what's your treatment plan in this case? Place 2 implants, one for central incisor, and the another one for the lateral incisor? No, we should not do that. And my treatment plan is placing the only one implant in the central incisor and make the distal cantilever on the lateral one. And with this side, I will make soft tissue grafting to increasing the thickness of the mucosa. In the central incisor, I use the socket seal technique, and in weight, I use the burr to divide the roots into the two parts. First in the buccal and the second in palatally, and remove the palatal, the part of the root, trim the remainder part in the buccal, and drilling and placing the implant in this area. Delivery the provisional bricks for the patient. You can see that I can remain the natural emergency profile immediately after making implant placement. 2 months later, the patient came back with the broken provisional bricks. But from the occlus view, we can see that I still remain the emergency profile in this area. And at this time, I decided to make a soft tissue grafting in the lateral side. With the first step, either measuring the mesodistal dimension of this area, using this blade to making a split technique flap, exactly the same technique with the first case I was introduced. Move on to the coronal to apical direction, and when I get about 10 millimeter, I finish this procedure and read the measuring, and it's ready to receive the graft. So let's talk about something about grafting material. So many authors recommend the auto-generate soft tissue grafting is also a gold standard for soft tissue augmentation. But nowadays we have a lot of alternative methods like the xenograft and allograft. The main different characteristic of the autogenous graft in comparison to the another one is contain the vital cell material. So it's very important to for the healing of the graft. And so in this case, I use the autograft with the two options. Option one is the connective tissue graft, and the second one is epithelialized connective tissue graft. Both techniques we have to caution with the damage the greater palatal artery. Exactly the dimension in the literature from the cervical of the posterior to the artery. The first is making a local aesthesia, then making the first incision in a split technique flap, and I can completely remove the graft into the palatal of the patient using the sponsor and suture to block the hemorrhage. After that, I making the epithelialization to get 1.5 millimeter of the connective tissue and ready to placing into the pouch. I want to describe more detail about this suture because it's a crucial role for the successful of this technique. The first, I make it through the apical to the coronal, pass through the graft and return in the apical. After that, I using the suture to pull it into the pouch that I created and so tie it. After that, I make some additional coronally suture to get the fully stabilization of the graft. And this result after 2 months is In the center incisor, I can remain the emergency profile, and in the lateral one, I can increase in the thickness of the soft tissue and get delivery the final prosthetic for the patient with the satisfied of my patient. So in the literature, when we make a soft tissue augmentation, especially in the aesthetic zone, we have a less recession of the mid buccal mucosa, and we have a thicker mucosa, buccal mucosa around 0.5 millimeter. In this case, we have a gingival recession on the buccal side, and from the occlusal view, you can see that they bone defect as well, the soft tissue defect in this area. So I made a survey for my colleagues with the question is which technique do you like to do in this case? The first one is the soft tissue grafting alone. The second one is hard tissue grafting alone, and the third is the soft combination with hard tissue grafting. So surprisingly, almost my colleague choosing to making a soft tissue graft only, but in this case, this is not enough. And in reality, I'm making a soft and hard tissue grafting in the same time. This is the post operatively outcome. Let's I show you the technique I did it in this case. I make the first incision more buccal to making a split technique flap, and after that I move to the palatal direction. When I reach the palatal part, I started to making a fully flap. So after I reflect the flap, I can remain the connective tissue in the buccal areas. And so I can placing the implant, making some bone grafting in this area, and after that I suture. So in this case, I left the connective tissue were exposed into the oral environment. I finished the grafting, and the connective tissue were exposed, and this is the result after the 2 months. I can get a horizontal dimension due to I make the bone grafting, and I have more keratinized tissues due to I using the soft tissue grafting before and after. And so it's very nice picture, and the patient are very satisfied with the result, as well as the site are ready for receive the final prosthetic. We move to the next case with the post lotting of the implant. The patient came back maybe 1 year after delivery the final prosthetic, and you can see that there are grays in the buccal mucosa around the implant. And so I decided to remove the prosthetic and making some soft tissue grafting in this area with the same technique I mentioned above, making a split technique flap and disinfection the implant surface using the measuring and using the collagen matrix from ACRO company to placing into the split technique flap and get the suture. So let I show you some case about the port injection site. In this case, when after we remove the root, we can place the implant, or we making a reservation. In some case, we cannot get the stabilization of the implant, so we could not make the immediate rotting. So we had to use the soft tissue to cover the bone grafting and the implant site areas. In this case, I used the pedicle connective tissue graft to cover it in the two side, because we allowed two incisor, central incisor, making a first incision, and from the posterior teeth to the anterior direction, making a split technique flap. You can see that the subepithelial, the connective tissue, we remove the connective tissue with remain the blood supply in the anterior, and to cover with this side, making some bone grafting as well as suture the graft in the vocally, and to cover the areas. Make the same technique in the contour side and suture. We left the side healing maybe 2 or 3 months, and I get fully maturation of the soft tissue of the connective tissue. So it's ready for making a prosthetic stage. So in some case, after we making a bone grafting, as well as they are serviceable loss in pre-operative, there no keratinized tissue at all, especially in the buccal. So we have to make some procedure to get more keratinized tissue. This picture explains that's why almost 100% of my implants case, I want to have a keratinized tissue around the abutment. The patient came back after the 3 years of the final prosthetic, and you can see that the result is very healthy of the mucosa around the implant. So in this case, in some case with the defection, and we don't have enough keratinized tissue, I using the apical positional flap to increasing the keratinized tissue volume. And the first incision, I make it in the junction of the keratinized tissue and mobile tissue. And after that, I make the split technique flap, trim it, and prepare for the grafting with in the palatal side. I using the collagen to create the shape that I need, making a split technique flap and control the plating. I can get the fully graft, and this is important step. We have to have a stabilization of this graft to guarantee for the healing, and this is the result after the 2 months. You can see that we can get enough volume of the keratinized tissue around the implant. So it's time to say goodbye, and I hope you like my case. And if you have a question, please contact me. And once again, thank you for your attention.
Yes, thank you, Dr. Tu, for your very brilliant presentation. And right now is Q&A section. Does anyone have question for speaker, for Dr. Tu?
Yes, I have a question.
Yes, please.
Dr. Tu,
Yeah.
from your experience, will the application of our collagen matrix sufficient to replace the autograft, the connected tissue graft, for the soft tissue augmentation as you performed in the study?
Yeah, and thank you for your so good question. So in my clinic, when I am making our autograft, the patient have a lot of pain because we have make the second surgical side. So with the collagen matrix, with the another alternative method, I can reduce the pain for my patient with the same result with the autogenous. That's good for the patient as well as the good for the doctor. But we have to make the right indication for the tissue graft in almost like making the apical positional flap or making the soft tissue augmentation to gain the more thicker flap. I recommend using the collagen matrix instead of using the autogenous graft. That is some old case, and I think in the future I can use more to make a better result.
Okay, so yeah, that will fit our idea of not using patients' tissues, because from getting the tissue, you create another wound for the patients, which will suffer for quite a while. So that's why we develop all the material to replace the autograft. Thank you.